كلكم عارفين إنه التوبيك is DDH. What about the incidence of DDH? لك خالد. هيدي عم تطلع شيء بالوجه. خالد عم بيطلع شيء بالوجه، ما بقدر اشوت my lecture. Okay. Most newborn screening studies, usually based on physical examination techniques, suggest that some degree of hip instability can be detected in 1 in 100 to 1 in 250 babies. يعني كل ولد بيخلق ما بين 100 عنده instability. اوكي عم بيطلع اصوات.
اوكي دكتور سامر الان
Is it clear now? عم راح الصوت. اوكي. Actual dislocated. يا جماعه بس احكي عم بيحكي حدا معي. في ايكو، في صوت عم بيفوت.
اوكي دكتور
Okay. Actual dislocated or dislocatable hips are much less frequent, being found in 1 to 1.5 of 1,000 live births. يعني إذا سألوكم قديش طلعوا بال1000 عدوا 1000 ولد بتلاقي منهم 1 ل 1.5 يمكن يكون عنده DDH. One should not forget that there is a late presentation of developmental dysplasia of the hip. It is found in approximately 4 per 10,000 children. I'm going to leave this lecture and I'll tell you something that you should know. In the past, كنا نسميها congenital dislocation of the hip. Nowadays, we call it developmental dysplasia of the hip. Why? Because they found that in many, the far majority of cases that end up having DDH are born with apparently normal hips, and the dysplasia develops with time. So they changed the name from congenital to developmental. بس ما لازم تنسوا إنه في أنواع of DDH that are present in the uterus. Okay? And these are the dislocations that occur with certain anomalies like arthrogryposis, like dystrophic dwarfism, and they call them teratologic hip dysplasia. Yani dysplasia is present within the uterus, not elsewhere. And then when the child is born, he is born with it. Developmental, it develops with time. So you have to differentiate between these 2 points. This is one thing you have to realize about it. Now, you should know another point. Why is dysplasia more common on the left side than the right side? لازم تعرفوا إنه the baby when he presents, the far majority are left vertex presentation. يعني الهip, يعني dysplastic is pressing on the sacrum. And this can provoke the dysplasia. So you should not forget these 2 points. There is no single cause of DDH. The basic structures of the human hip joint are well formed by the 11th fetal week. And this is a question I personally put. When would the basic structures of the hip be formed? And you should answer the 11th. I put various periods. You should answer the 11th fetal week. Subsequent development of the hip requires a continuous synergistic molding and growth of the mature femoral head and the acetabulum. Any process or event that interrupts this interaction can result in structural abnormality and instability. Those hips that dislocate early during the course of fetal development will have extreme anatomic abnormalities. They will be so rigid if you look at dystrophic dwarfism, if you look at arthrogryposis, they are so rigid and very difficult to treat. And these are called teratologic dislocations. These are dislocations that occur within the uterus. They are present within the uterus. The risk of DDH has been found to be 34% in identical twins, but only 3% in fraternal twins. The frequency in siblings is approximately 6 to 7%. If one parent, one sibling, يعني وولد, have DDH, the risk to subsequent infants rises to 36%. The genetic influence may also be seen in comparisons of different ethnic groups with high rates among the Lapish and very low rates among the Bantus. Infants have been in the breech position, يعني الإجرين presenting before the head, during the 3rd trimester and or perinatally have a higher risk of DDH, as high as 20% for those in frank breech position. يعني البريتش, the incidence of DDH is much higher than the vertex presentation. And the rotation of the hips in the breech position does not occur normally so as to form the acetabulum. An increase in the incidence is also found with conditions typically associated with intrauterine crowding. What do we mean by intrauterine crowd? Oligohydramnios, يعني ما بكون عندهم amniotic fluid. مشان هيك it will compress the fetus. And this has been associated with DDH. Another point, primigravidas, يعني أول ولد بيكون كل المسلز tight. These compress the infant and could lead to DDH. Congenital recurvatum. What does this do? When they have a congenital recurvatum, we think of the muscles that have been stretched, resulting in pressure on the hip, and therefore this has been associated with DDH. Even dislocations of the knee as part of a syndrome, such as occurs with arthrogryposis, can lead to DDH. And we found that DDH is more common in patients, children with congenital muscular torticollis. Torticollis, yani sternocleidomastoid, will be short. Also, there have been reported an incidence of children having DDH having metatarsus adductus. Postnatally, a high incidence of DDH is found in those societies where infants are customarily strapped or swaddled with the thighs adducted. يعني لما بيربطوا الإجرين سوا وبيلفوهم، لا فكرة إنه الإجرين بيطلعوا دغري، بس لما بيعملوا هيك شو عم بيعملوا؟ عم بيحطوا ضغط على الورك, and as a result they have a high incidence of DDH. For a hip joint to develop, there should be a continuous normal range of free motion. When diapers are applied, the hip should be freed لحتى الولد يحرك إجريه, because this stimulates the formation of the acetabulum. DDH is associated with certain neuromuscular conditions and genetic syndromes, especially those in which decreased or abnormal fetal movement is a feature, such as arthrogryposis اللي حكيتكم عنها and spina bifida. طلعوا بالصورة على اليمين. The child has a fixed external fixation, extensive aspect of the left knee. He is stiff. He cannot move his hip, and as a result, the hip does not develop. Or while in the uterus, they don't form, and they end up with a teratologic hip. Although ligamentous laxity has been suggested as a risk factor, DDH, لازم تخلوها ببالكم, is not especially associated with genetic conditions such as Marfan's, Ehlers-Danlos syndrome, Down syndrome, in which generalized joint laxity is a prominent feature. انتبهوا لها, لأن we have a normal incidence of DDH in Marfan's and Ehlers-Danlos. يمكن Down syndrome شوي أكثر, but you have to keep this in mind. Slides, in infants who are otherwise normal, the most important risk factor for DDH are the female gender. Females are far more common to have DDH than males. Some say 9-1, some say 5-1. DDH occurs in families, and we spoke about breech positioning. What about the diagnosis? هيدي اللي حبيت يحكوا بالميتينج خالي عن الأوترلوني وعن البارلو تيست, how to demonstrate it, how to examine for it. وين بيحطوا الأصابع النصانيات بيحطوهم على الجريتا تروكانتا, والأصبع الكبير بيحطوه على اللسة تروكانتا, and they abduct the hip. If the hip goes in, then it is called the Otterloni sign, and it tells you that there is a dislocated hip. If the hip, upon downward pressure, goes out, then it's a subluxatable or dislocated hip, and this is called the Barlow's test. هيدي ما حكوا عنها, هيدي اللي لازم يعرفوها. For newborns, neonates, the mainstay of physical diagnosis has been the palpable sensation of the hip sliding out of or into the acetabulum. خلينا لكم بالuniversities يلي عنا, 2 American universities. The residents, while in training, there is a certain rotation that the juniors and the second-year residents are obliged to rotate through the nurseries. They examine every newborn baby to get the idea of how to do an Ottoloni and the Barlow sign, but gently. in a warm area, in a comfortable baby, in a non-crying baby, and do this examination, because this can help us tell us, plus the history, plus the method of delivery. It will help us know whether that child has a DDH or would develop it possibly with time. Barlow's test is a provocative maneuver. يعني نحن عم نحركش فيها, in which the examiner attempts to subluxate or dislocate the hip by pressing gently downward on the flexed adducted thigh. The mechanism: attempt to sublux the unstable hip. You should perform it with caution, and you should examine each hip individually. مش تعملوا اثنين سوا, هيدي تجليطة بنسميها. The infant should be lying supine with the diaper off, and he should be warm, relaxed, and calm. You could have a nice, pretty nurse by your side, and you will be calm. The hips should be flexed to 90 degrees. Technique, the whole purpose, you should stabilize the pelvis with one side. That's why I'm telling you, do one hip at a time. Place the index and the middle finger over the greater trochanter. Place the thumb medially at the inner thigh in the inguinal crease. I usually put it on the lesser trochanter. Gently adduct the hip while applying downward force. Gently, I repeat, gently. This tells you how to do the Barlow maneuver for routine screening of congenital dislocation of the hip. Note that the examiner gently stabilizes the infant's left hip and lower extremity and places the left hand around the right thigh and index and middle fingers over the greater trochanter. تبقوا كيف الهip, you're provoking it to come out. طلعوا على red arrow. Don't forget this. So, if you have a positive hip tongue, this is a sign that your Barlow sign is positive. It means that the hip came out of the acetabulum. The Ottoloni test is a reduction maneuver performed by abducting the flexed hip while lifting gently forward under the greater trochanter. قالوا عليا بسيطة هينة. You stabilize the other hip with the other hand and the pelvis while you work on the opposite hip, and you reduce the hip if it's subluxed. By reducing it, it will give you a clunk. And this is a positive Ortoloni maneuver. Palpable luxation or reduction of the joint constitutes a positive test. Most high-pitched clicks are transmitted from the greater trochanter or knee areas and are inconsequential. Yeah. You can have other clicks. You should be able to localize the click to the hip region. For instance, the tensor fasciolata can slip on the greater trochanter and give you a click. The iliopsoas can give you a click. You have to be able to distinguish between the two. Between 3 and 6 months of age, the soft tissues tighten sufficiently that a reduced hip does not dislocate. with Barlow's test. And a dislocated hip cannot be reduced with an Orthology test. Why? Because the tissues become rigid. They contract. And therefore everything remains in its place. يعني إذا عندك hip موجود بالacetabular, it will be fixed and you cannot dislocate it. ما فيك تعمل لها Barlow's test. وإذا عندك hip dislocated, all the muscles around the hip are contracted. And if you try to reduce it, it will not reduce. Hip abduction, inflection will be limited on the affected side, and the thigh will be foreshortened. Ya Shabab, in exams, I asked many of you Yemenis, I asked them a question. I asked them at the 3 months, please examine this child. We have a child with a dysplasia. I asked them, did you hear a click or clunk? They say yes. I told them no. Why? Because everything is rigid in its place. Neither the dislocated hip will give you a clunk. Now, if this infant was a newborn, it's a completely different situation. Please don't forget this. What do we find at 3 to 6 months? إذا بتطلعوا على الولد مصور, you see that one of both hips has a matter of fact, but one is more than the other. They have limitation of abduction. And this is one of the signs of DDA. Okay? So don't forget this. إذا سألناكم after 3 months شو بتلاقي بالولد؟ تقول limitation of abduction وبس. This shows it further. Now, in unilateral cases, the shortening is conveniently demonstrated by the Galeazzi or Alice test. It's shown in the slide above, in which the infant is positioned supine with the hips and knees flexed so that the relative height of the knees can be assessed. طلعوا لي على الصور, طلعوا على الكني, طلعوا على level. You see, one is short. It tells you that one is dislocated. But mind you, the infant should be on a flat, rigid surface, because you can be confused if it's so. This is another, and this tells you this child has a positive Galeazzi sign with apparent shortening of the right lower extremity. So remember, you have the Barlow, you have the Ortolani, and you have the Galeazzi or the Alice sign. Don't forget these. We love to ask these questions in exams. What about the skin folds? Asymmetrical skin folds are commonly mentioned as a sign to look for, but unfortunately, this sign is not always reliable because normal children may have asymmetrical skin folds, and children with dislocated hips may have symmetrical folds. So please, إذا سألناكم بالoral عن الfolds, say this is very unreliable. You can be confused. You can condemn a child to have a DDH when he's totally normal. This child has an asymmetrical skin fold with difference in levels of the popliteal and gluteal skin clefts. This is what test? This is called the telescoping test. The telescoping test, where you hold and press down on the hip. If it's dislocated, تعمل مثل telescope, طالع نازل, طالع نازل. Okay, so keep this in mind. Okay, so please. Telescoping, hip dislocated, it's not fixed in position, and you can move the hip within the soft tissue. After these children begin to stand, a flexion contraction usually develops at the affected hip. And what do they have? امبارح فلشة Dr. Igasi patient with DDH bilateral, and he failed to mention something about lumbar lordosis. Lumbar lordosis in bilateral DDH is a problem. Why? Because the stress and strain on the spine is bad. They will suffer from back pain when they walk. And that's why if you have a bilateral DDH, they will have a duck waddle gait. A duck waddle, مثل البطة. And this can give the child pain. The patients walk, if it's unilateral, with gluteus medius insufficiency because of the high position of the greater trochanter. This is a positive Trendelenburg sign. إذا بتقشعوا على الشمال بتقشعوا. Why is the pelvis going down on the right side? The reason why is that the gluteus medius is insufficient. It is lax due to the DDH, and as a result, it is inefficient to raise the pelvis up. This is the Trendelenburg sign. And they also would have, with respect to this, a Trendelenburg gait. In unilateral cases, the limb length inequality may either contribute to a limp or may be compensated by toe walking on the affected side. Once again, limitation of hip abduction inflection is a useful finding in all age groups. This is what I told you about. They will have limitation of abduction. Why? Because the hip is posteriorly displaced, and when you abduct the hips, all the muscles are contracted. Therefore, you'll have limitation of abduction. Lesser degrees of dysplasia may include a functionally stable but anatomically insufficient hip. These situations are ordinarily clinically silent in young children. The abnormality may be discovered incidentally, but more often presents in later life as hip pain and degenerative arthritis. ما بيصير ما تكونوا شفتوا بالتريننج تبعكم مريض بيقول لك حياتي ما شكيت من وجع فجأة صار عنده وجع بوركه، بعدين تقشعوا على الصور اللي عم تاخذون انه there is degeneration and luxation of the hip. What about imaging? We start with ultrasound. ليش ما نبلش بالالتراساوند؟ لأن اللاند ماركس يلي بنقشعهم على الصور مش موجودين بالنيو بورن لحتى العمر 4 أشهر. So we need something to tell us about the hip. But mind you, إذا يلي عم بيعمل الالتراساوند ما عنده experience, he can miss a lot of cases. He can overdiagnose DDH and he can underdiagnose DDH. Ultrasound allows visualization of the cartilaginous and soft tissue structures before femoral head ossification. Now, there are two types. There is the static and there is the dynamic. The static is done by graft and the dynamic is done by harsh, I think. Static acetabular morphology described by graft is based on two angles measured in the coronal plane. Why do we say coronal plane? The child is put on its side as we're doing the ultrasound. A reference line common to both angles. This is the reference line. It's first established along the lateral, and another line is established at both walls of the acetabulum. Then you can see that the head is well localized over here. This is a good ultrasound. There are two angles. One is called the beta and the other is called the alpha. The beta angle is subtended by the iliac line and a line tangential to the bony roof of the acetabulum. عم تعملوها بالcoronal plane. فإذا عندك the upper line, the bony roof. The lower line is the lower. So this is the reference line through the iliac line. إذا بترسموا لها زيح, you measure this angle between this and the tangent to this, and this line and the tangent to over here. So it gives you the beta angle and the alpha angle. انتبهوا لهي. عم جرب جهدي فسركم كيف تعملوا الالتراساوند. The beta angle is subtended by the iliac line and the line tangential through the cartilaginous labrum. In general, a normal mature infant hip should have an alpha angle of 60 degrees and the beta angle of 55. يعني لحتى نرجع لورا. This is the alpha angle, which should be 60 degrees. And this angle should be 55 degrees. So if it varies between this and this, then you judge whether there's dysplasia or not. In the dynamic, he does the measurement while he's moving the hip, and you can see whether there's subluxation on specific motion. هيدي الفرق ما بين تبعت graph و harsh. The beta angle I mentioned, coronal sonograms. These are coronal, يعني كيف تجيبها لما المريض الولد نايم على جنبه. You can tell the acetabulum from the height and below. Okay? This is the dynamic. طلعوا هون. طلعوا منيح. إذا بتقشع هالورث موجود هون. This is the alpha angle. وهذا الورث موجود هون. The beta angle. Now, لما بيتحرك بتشوفوا إنه الhead is subluxing and it becomes uncovered. Over here it is covered. And this is how we judge whether there's a dysplastic hip or not. Graft classification describes the cartilaginous and osseous anatomy of the acetabulum, noting the depths and shape. Coronal plane is imaged by placing the transducer over the lateral aspect of the hip. Type 1 is a normal hip. Type 2, less than 3 months, physiologic immaturity, and 3 months, mild dysplasia. Type 2, the hip is immature or mildly dysplastic and has a more shallow acetabulum with a round rim. In children younger than 3 months, most of these will spontaneously resolve. In children older than 3 months, the deformity is expected to persist without treatment. Type 3 is dislocation. The acetabulum is shallow, the cartilaginous roof is displaced with eversion of the labrum. Type 4 is a high dislocation. The acetabular cup is flat and has the worst prognosis. The femoral head is laterally and superiorly displaced. The labrum is interposed between the femoral head and the lateral wall of the ilium. So you have to know these. In 1, it's normal. In 2A, it's immature. 2B, it's greater than 3 months. It is in between. 2C, acetabular deficiency. 2D, everted labrum. 3, everted labrum. And 4 is dislocated. Don't forget this. The percentage of coverage of the femoral head can also be assessed. I just want to drink water. In dynamic ultrasound of heart assessment, the position of the femoral head with respect to the posterior bony wall of the acetabulum is monitored as the hip is stressed. يعني عم نحرك الورك, we're stressing it with a modified Barlow's test. The use of ultrasound in the routine screening of all newborns is neither cost-effective nor practical. The procedure is so sensitive that routine use has resulted in overdiagnosis above the expected incidence of DDH. The presence or severity of ultrasound abnormalities in infants who have otherwise normal hip examinations does not correlate with ultimate outcome. Routine ultrasound screening of newborns has not been shown to reduce the prevalence of late diagnosed cases of DDH. Ultrasound evaluation at 3 to 4 weeks after birth is useful as an adjunct in those patients having equivalent findings on initial nursery examination and for those in high-risk groups. Ultrasound can be used to check hip stability and document reduction during treatment or at the completion of treatment. The greatest advantage is that serial examinations can be done without exposing the infant to ionizing radiation. Femoral head ossification usually begins by the age of 6 months, and plain radiographs then become the primary imaging modality for DDH. So I use between 4 and 6 months, but if you're asked in an examination, you should say, I would be glad to use plain x-rays at 6 months. But the disadvantage is that these children are receiving radiation therapy. Radiography also remains useful to evaluate the distorted anatomy of the teratologic dislocations. Traditionally, several lines are projected across the visible ossified portions of the pelvis and proximal femur to assist in interpretation of the plain films. You have to know what is Helgen-Reiner's line, what is Perkins, what is Shenton's line. They are commonly used as illustrated in the next slide to determine the alignment of the proximal femur to the pelvis. The acetabular index provides information about the contour of the acetabulum. Is it flat? Is it narrow? Is it small? This is a diagram that I love. You have to know what is Perkins' line. This is Perkins' line. It is a line drawn perpendicular to the horizontal at the outer margin of the acetabulum. Helgen-Reiner's line is the horizontal line drawn in between both triradiate cartilages. Shenton's line passes from the inferior aspect of the neck to the inferior aspect of the superior pubic ramus, and this should be in one arc. So please, don't forget, the head should be present at the intersection of the Perkins line and the horizontal line of Helgen-Reiner. It should be in the lower quadrant. In DDH, this head moves out and is a show the size of the head is smaller than the normal size. The acetabular index is a line drawn tangentially to the upper margin of the acetabulum with respect to the Helgen-Reiner's line. This angle at birth is more than 20, but then it declines. Why? Because you'll have better development of the superior margin of the acetabulum. Shenton's line can be interrupted, and this is a sign of DDH. This is another better line showing this. We stress this because we ask this in exams. Don't forget this. Draw this line, have it in your head, and never forget it in your life. Never forget it in your life. These are on the x-rays. طلعوا تقدروا تسموا هوني Helgen-Reiner's, هوني Perkins line. When الhead out. طلعوا على Shenton's line. Shenton's line is here and Shenton's line is here. It's interrupted. Over here, تعملوا هيك, it comes, it's not interrupted. So don't forget these. This is a 13-month-old child with congenital dislocation of the hip. لازم تاخدوا صورة مثل هاي وترسموا عليها وتتعودوا على الأسامي تبع كل لاين والميجرمنت تبعكم وكيف تعملوا الاسيتابلا اندكس، كيف تعملوا the cervical obturate line, cervical obturate line, or Shenton's line. Is it interrupted? So you have to pay attention. There's another point. Over here you have the teardrop sign. There's a special line that we draw from this teardrop to the medial aspect of the metaphysis. You see that it's not symmetrical. It tells you that this is dislocated laterally. So, I'm speaking about the superior and medial gaps described by Bryan et al. To predict treatment outcome. The superior gap is defined as the distance between the center of the femoral head, metaphysis, and Helgen-Reiner's line. تشعوا هي الميتaphysis وهي Helgen-Reiner's line. You draw a line from here to here, and this gives you the superior gap. The medial gap is defined as the distance between the calcar of the femur and the lateral pelvic wall at that level. يعني بتكون I use the teardrop. and you measure the distance and you compare it. It's a comparison line. You see that one side is larger than the other. What about CT and MRI and arthrography? These do not play a significant role in the primary diagnosis of DDH. Each modality has specific uses in treatment. CT is currently the study of choice for assessing. ما بتكونوا بالoperating room and you do a closed reduction. You cannot see clearly between the head and the acetabulum while the patient is in a hip spica. So we use CT. It tells us with the reconstruction whether that hip is well reduced or not. But we don't like it very much because of the radiation exposure. Sedation is seldom needed as the patient is immobilized in the cast, and spiral acquisition techniques for CT have decreased the time required for these studies. A method of hip reduction and spica cast application with the infant in the MRI scanner has been investigated, but is not yet feasible in most areas. MRI is still not usable, but the CT is usable. It has a problem of radiation, but it gives us an accurate idea about the reduction. Both CT and MRI data can be presented as three-dimensional images, and software is available to manipulate these images when planning various osteotomies. Now, let us see. From infants from 6 to 18 months of age. This is an anterior-posterior röntgengram of the pelvis obtained with the patient in a spica cast after closed reduction. Note the difficulty in assessing the position of the femoral head. We still cannot see it in this plain X-ray. أنا ما بكون مرتاح شوفها. Okay, but CT scans confirm bilateral reduction of the femoral head in the acetabulum. Shown, it's still in the acetabulum. It's well reduced. Arthrography is unparalleled for showing dynamically the soft tissue impediment to reduction and is useful to confirm position and stability in closed or open procedures. But it is an invasive study that requires sedation or anesthesia. This is arthrography in a patient who has a dislocated hip. We want to see what structures could interfere with the reduction of the hip. So we request an arthrogram. So we can see, we have an idea that there are many structures. So this would give us an idea of the structures that can obstruct. The pulvinar fat pad, the inverted labrum, the transverse ligament, and the ligamentum teres. The same patient at age 4 years, note the mild residual dysplasia of the left hip because they identified these structures. Another patient is an arthrogram of the right hip of an 18-month-old girl with irreducible dislocation. You see that there is capsular constriction. يعني امبارح كان حاضر سمعتوني عم بقول capsular constriction secondary to pressure of the iliopsoas tendon would interfere with reduction. So this tells us one of the interference is the capsule. Second is the labral. All babies should be screened for hip dysplasia. However, the scope, timing, and methodology of neonatal screening for DDH are areas of current controversy. Hips dislocated at birth should be treated with the exception of certain teratologic situations. However, 75 to 90% of hips found to be subluxatable at birth would spontaneously stabilize within a few weeks. A reasonable protocol is to re-examine all hips having questionable nursery examinations and infants with recognized risk factors for dysplasia at 2 to 3 weeks after birth. Hips with persistent laxity at that point should be treated. Ultrasound may be used at week 3 to 4 as an adjunct in questionable or high-risk situations. Hips that are stable at the 3-week examination but show dysplastic anatomy on ultrasound should be reassessed 2 to 3 months. At 2 to 3 months. If the dysplasia persists, treatment is indicated. The fundamental goals of treatment are the same regardless of patient age. Concentric reduction should be obtained and maintained with a minimum of risk to blood supply of the capital femoral epiphysis. Yesterday, Dr. Aigazi showed you a case that following a reduction, the patient developed osteonecrosis of the head. Why could this happen? It was due to repeated surgeries and probably injury to the blood supply to the head. So you have to keep this in mind. You should respect the head. You should respect the position of the hip in the cast. You cannot apply too much abduction. We, as students in pediatric orthopedics, we used to know the human position. This was created by Salter, not more than 90 degrees and around 40 to 60 degrees abduction in the hip spica. There's the zone of Ramsey, which is a zone in which you can decide if the hip is stable, and then you apply your cast. You should not put too much pressure because you damage the femoral epiphysis. The later DDH is diagnosed, more complex interventions are needed, and the risk of complications increases. Infants whose hips are subluxatable, reduced but dislocated, or dislocated but reducible, can usually be treated by splinting the hips in flexion and gentle abduction. Most of these infants will be younger than 6 months of age, although occasionally the hips of a slightly older infant remain otoloni positive. Sometimes abduction splinting is used to achieve reduction of a dislocated hip in infants. This procedure must be done with care, avoid forced positioning, and the attempt should be abandoned if not successful within 2 to 3 weeks. There are various methods of abduction. One is the fresh capillo, one is double diapers, one is the Craig splint, as is shown over here, one is the Pavlik hernias. The Pavlik hernias is very popular. Why? Because it's a dynamic splint. It lets the hip to continuously move within the acetabulum in the contained position. But you cannot apply this to uneducated mothers because you should limit the amount of flexion to 90 degrees and the amount of abduction. If you apply too much flexion and abduction, one, you'll have posterior subluxation of the hip, and second, avascular necrosis. Another point, you should treat this patient not more than 2 to 3 weeks in a Pavlik hernia. And you find that the hip is not being reduced, then you should choose some other method. There is also the von Rosen splint. These are the various splints that I came across. The most popular abduction splint used in the United States is the Pavlik hernias, although it has some limitations and potential problems. It should be properly applied. The upper strap should be equivalent to the nipples. Keep this in mind. You should not overstrain the child. Look at the child. He's laughing and telling you, thank you for applying a very nice splint. This is when it's applied for developmental dysplasia at the age of 2 months. At 5 months of age after reduction in Pavlik hernias, you see that you've got the contained hip. On one side, it's still a bit subluxed. It is an active device in that normal muscle function is required. It is not effective in patients with paralysis or spasticity. Don't use it in spastic patients. Don't use it in paralyzed patients because there won't be motion. We believe that the motion of the Pavlik hernias stimulates the acetabulum to form. If the anterior straps hold the hips hyperflexed, you can damage the femoral nerve, or you can end up having an inferior dislocation, and you can damage your posterior wall. So you have to be careful when you want to use a Pavlik hernia. If you don't have an educated mother, don't use it. The persistent use of the Pavlik hernias with the hip in a posteriorly subluxed position will result in failure of development of the posterior wall of the acetabulum. And this is called the Pavlik disease. So if we ask you in an exam, what is the Pavlik disease? Say it's too much flexion. By tightening the anterior straps, the hips go more than 90 degrees, and as a result, the posterior wall of the acetabulum does not develop well, and they end up with subluxation or dislocation. Prone positioning of the infant wearing the hernias should be avoided because the combined effect of the hernias and the weight of the torso forces the hips in maximal abduction, increasing the risk of ischemic necrosis. So keep this in mind. Good results are also obtained with other abduction splints, such as the von Rosen splint or various plastozoid orthosis. It is critical that forced or extreme abduction be avoided. Regardless of the splint chosen, concentric reduction must be verified within 2 to 3 weeks of initiation of treatment. If the reduction is not confirmed within that period, the splinting device should be abandoned and another method of treatment chosen. When successful, The abduction splint should be worn on a full-time basis until the hip is stable, and part-time wear is recommended until acetabular remodeling is confirmed. This tells you the pathogenesis in relation to age of the child at the onset of treatment. How long do they take? They're at 1 month, they around 3 to 4 months. 1 to 3 months, 7 months. And 3 to 6 months, 9 months. So you have to pay attention to this. Most infants older than the age of 6 months, those whose hips are not reducible with a simple Ottoloni maneuver, and those in whom splinting in abduction fails will need a more normal closed or open reduction of the hip. So, at this period, I would like to ask, are there any questions? Dr. Khalid, Dr. Salah, any questions?
دكتور الشباب مستمتعين ومستمرين
الشباب فهموا كل شيء؟
شو
يا
واضح
شباب؟
جدا يا دكتور.
فهموا كل شيء؟
اي واضح جدا دكتور.
يعني إذا في شيء أسئلة يسألوني.
اوكي انا حتى بسأل الشباب اي واحد معه سؤال يحطه في الشات واحنا نبلغ للدكتور جون.
طيب. So I'll carry on. Closed reduction. Closed methods are preferred up to about the age of 2 years, but the reduction must be obtained and maintained without excessive force. إذا بتلاحظوا دايما عم بقول don't apply excessive force. Forcible maneuvers and forced rigid immobilization carry a high risk of ischemic necrosis. You can do an autogram and see what are the structures that are interfered. And this is what I routinely do before the age of 2 years. Otherwise, an autogram is useless. This shows you a bilateral hip dysplasia. You have to realize that the blood supply to the femoral head is through 2 main vessels. The major one is through the medial femoral circumflex. In addition, there is the branches from the lateral circumflex femoral artery. And these supply the head. But طلعوا على الصورة على الإليوبسوس. طلعوا كيف مرأة الفسل ما بين الإليوبسوس والنك. هيدي اللي حط البوينت عليها. When you put too much forced abduction, this will kink the vessel. It would decrease the blood supply to the head, and you would end up with necrosis. I want to show you this. I got this from one of the textbooks. This is compression of the medial circumflex vessel. عم بتفرجينا الإليوبسوس وين؟ عم بتفرجينا وين الvessel. This can be compressed over here on abduction. The use of traction before closed reduction of the hip has become less common. The goal of traction is to gently and gradually stretch the soft tissues surrounding the hip so that closed reduction can be achieved without undue force. Now, هيدي كنا نستعملها كتير بالماضي, but let me tell you something. When we apply traction and we apply a Bryant's traction, we have to have a Bradford frame where it has a hole and the child doesn't need to detach the traction each time it passes a bowel movement. I'll tell you, we don't like the traction. We found that it's useless, and I'm not using it anymore. However, comparison studies have shown that adductor tenotomy and immobilization in the human position, hips flexed to 90, abducted to 45 degrees, and neutrally rotated, can achieve comparably low rates of ischemic necrosis. Close reduction should be done under general anesthesia with an autogram used to verify the position. A concentric reduction must be obtained with no more than 5 millimeters of contrast pooling medially between the femoral head and the acetabulum, and with no soft tissue interposition. With the hips flexed, a safe zone, this is the safe zone I spoke to you about, the safe zone of Ramsey, of abduction, should be assessed. An arc, stable positioning between redislocation toward adduction and the limit of comfortable unforced abduction. يعني بتحطوا الولد على جنبه. You test the amount of abduction from neutral position in which the hip remains within the acetabulum. Anything more that it disturbs the reduction or less should not be used. This is called the safe zone of Ramsey. If the safe zone is unacceptably narrow, in adjunctive procedures such as percutaneous adductor tenotomy may be indicated to release soft tissue tension and increase the range of available abduction. يعني بدي أقول لكم إياها. You reduce it by abduct. The hip is reduced. You're happy, okay? But you find that as you go from 45 degrees of abduction to neutral position, that hip dislocates, indicating that you have tight adductors. Then you should do an adductor tenotomy. This is the safe zone of Ramsey. So what أنا هيدي الزون يلي الهip should remain stable in the acetabulum. This is a low zone if they dislocate. It's used to determine the acceptability of close reduction of congenital dislocation of the hip. You see, this is the zone. It's drawn in triangles, and it would tell you how stable the hip is in a certain position. And if you want to apply a bilateral hip spica, you apply it with hips well reduced within the safe zone, not under forced abduction, and it will be stable. The technique of application of a spica cast for congenital dislocation of the hip. Note the positioning of the patient in the human position. This is the best position we like to apply. 90 degrees, around 40 degrees or 45 degrees of abduction. You see this on this slide. The knees should be flexed, not extended. Because if it's extended, you'll be applying forces on the hip. We don't want this. A pad should be applied when you apply the cast on the abdomen, as not to create pressure. This shows you of how we have a special hip spica cast in a child. This is how we hold the child. We apply cast. We put the padding underneath the cotton roll on the abdomen and chest. The knees are flexed, and that's the best position. The infant is then immobilized in the spica cast in the human position. Remember that the human position is flexion of about 100 degrees and abduction of about 45 degrees for 3 to 4 months. Part-time abduction bracing should be continued until acetabular remodeling is complete. This is the nurse so happy and the child so happy. You have to create. I recall once I applied the hip spike, I told the residents to rearrange the cutting levels and everything. The nurse calls me in the middle of the night. She says, they didn't leave him a space to shit. Well, you have to keep this in mind. And we like to use the fiberglass. Why? Because the other forms of glass, the child is peeing and mothers are not cooperative, the diapers are not good. As a result, they will soak the regular cast and it will break in no time. It is not unusual for infants to be treated by closed reduction to achieve stable hips, but to require a secondary acetabular or femoral procedure to correct the residual deformity. يعني ما تنسوا ان شاء الله افكركم انه اذا احتاجتوا سبايكا كاست كل شيء ورجع كل شيء بعدين بتلاقي on follow up that acetabula is really not forming well, so you have to do some procedure to assist the acetabulum in forming. Failure to obtain a concentric closed reduction of the hip is an indication for open reduction in all age groups. Any hip in which extreme positioning is required to maintain reduction should also be treated by open reduction. In general, children older than 2 years of age will require open reduction. Anteromedial and medial approaches have most often been recommended for younger children, 2 years old or younger. This is called the Ludlow approach, where we go medially and we can reduce it, but we cannot do a proper capsular. Cannot do it, point blank. And of course, you have to pay attention to any nerve present over there that you could damage. So this is very careful. You have to obturate the nerve can be damaged in this approach. I don't like the Ludlow approach. All approaches include division of the origin of the adductor longus. One anteromedial variation then proceeds between the pectineus medially and the femoral neurovascular bundle laterally. Division of the psoas tendon allows direct access to the anteromedial hip capsule, with exception of an inverted labrum. Obstacles to reduction can be easily visualized and removed. However, there is no opportunity to perform a capsulorrhaphy, or even if at the same time you want to do an osteotomy through this exposure. So you can see why I don't value this approach. A potential disadvantage is that the medial femoral circumflex artery is in the field of deep dissection, which some believe increases the risk of ischemic necrosis. Alternatively, after division of the origin of the adductor brevis, the pectineus may be retracted laterally, and the deep dissection can then proceed either anteriorly or posteriorly to the adductor brevis. These two variations are conceptually less direct than the anteromedial approach and are not well suited for high dislocation. Other indications and limitations are similar. The most commonly used anterior approach for open hip reduction is that of Smith-Peters, generally modified by using a bikini incision parallel to the groin flexion crease. This is the approach we use. Look at it well. Look at the inguinal ligament. Look at the iliac crest. You have to pay attention to the lateral femoral cutaneous. But you reach the tensor fascia lata, and the lateral femoral cutaneous nerve comes in your face. You separate the periosteum after making a longitudinal incision, straight, مش مليون incision in the apophysis. Then you elevate the periosteum and you arrive at the capsule. This is the capsule. You have the iliopsoas causing a kink. It causes a kink and prevents it from reducing. You have to keep this in mind. This shows you طلع الهيب، طلع على الهيد، طلع على الiliopsoas. So the iliopsoas and the capsule are factors to prevent reduction. This was not mentioned yesterday, but this is a very important factor. I have a whole load of cases, and this is what I found. Of course, besides the pulvinar fat, besides the ligamentum teres, besides the labrum, besides the transverse ligament, but this is also important. We go through the capsule. We make a T incision. Once we've removed all the structures, we try to remove them in such a calm, nice, gentle way. Only the essential structure. We don't remove the labrum. We make multiple vertical incisions through it. Then you find that you reduce the hip. Dissection is deepened between the tensor fascia femoris and the sartorius, mobilizing the origins of the tensor fascia femoris from the iliac wing. This shows you it. Division of the origins of the rectus femoris then gives access to the anterior, superior, and lateral hip capsule. A separate tenotomy, either percutaneous or open. The adductor longus is recommended. We should tenotomize. Now, we've reached the hip. The iliopsoas is tenotomized. The capsule is just facing you. All of the impediments to reduction can be addressed via this approach. If an inverted labrum is identified, it can be released by making several radial cuts in the tight area. The labrum should not be excised. And then you reach the center. The ligamentum teres should be excised. The pulvinar fat pad or fibrofatty tissue should be removed. The joint capsule is released. The inverted limbus is incised several vertical strands so as to relax it. And the transverse ligament at the inferior aspect of the acetabulum is released. This shows you the result after removing all. Look at it here. Look at the labrum, it's free. So you reduce your hip. Look at the labrum in this slide. It's vertically cut. We don't excise it. Radial incisions in the acetabular labrum and removal of all the pulvinar fat pads from the depths of the true acetabulum. This approach is suitable for all age groups. The dissection preserves the medial femoral circumflex vessel. Capsulorrhaphy and pelvic osteotomy can be performed through this approach, while in the Ludlow or the medial approach, you cannot do it. This shows you the anatomy and on the vessels of how you should be careful. What you should do as to not interrupt the circulation of the medial circumflex femoral artery. You should respect the arterial supply of the head. This is the way we do a T-shaped incision in the capsule, because not always. You can see it in high-riding hips as such. Once you've done the capsule, then you can work on it. Once you repair it, you do it in flaps. I wish I had a better slide to show you of how we repair the capsule. This is a developmental dislocation of the hip after anterolateral open reduction. Mind you, not at this stage, you won't need an acetabular plasty or an osteotomy. You won't need a varus because you still have a soft tissue interruption. And if you get a good reduction on closed or doing an open reduction with excision of these material and the hip is stable, you won't need it. This shows you it at 7 years, a patient who had an open reduction. Post-operative immobilization is in the functional position, the human position, with approximately 15 degrees of flexion, 15 degrees of abduction, and neutral rotation. Femoral shortening at the time of open reduction has taken the place of preoperative traction for reducing soft tissue tension around the hip. This procedure is virtually always necessary for children older than age 2 years, but should be considered in each patient. A separate lateral approach is necessary. The hip is reduced, a subtrochanteric osteotomy of the femur is performed, and the soft tissues are allowed to retract. The resulting overlapped segment of the proximal femur is resected, and the femur is internally fixed with a plate and screws. Varus and rotation can be adjusted through this osteotomy as needed for hip stability. It is important to avoid excessive retroversion of the femur, especially if concomitant pelvic osteotomy is done, as this increases the risk of posterior redislocation of the hip. In older children, the acetabulum will be more severely dysplastic. Anterolateral coverage will be insufficient. It is frequently necessary to consider concomitant pelvic osteotomy at the time of open reduction to ensure stability of the hip. The Salter innominate osteotomy will redirect the acetabulum to restore approximately 25 degrees of lateral coverage and 10 degrees of anterior coverage. But this is at the expense of uncovering it posteriorly. How do we do a Salter? يا جماعة, when you're doing an osteotomy, you should do it in a way that was first described. The periosteum on the medial aspect of the ilium should not be divided. You have to just reach the inner cortex. And then when you want to open it up, you can use the Faber position. Put the hip in the Faber position. Flexion, abduction, and external rotation, and apply pressure. And the hip would open up. You should remove a wedge of bone from the area of the anterior superior iliac spine and insert it over there. This is called the Solta. In B, you have the Howard seal. This is done at a later date where you have to do osteotomy through the superior pubic ramus and the inferior pubic ramus. Why? I'm asked, why do we have to do this? Because the Solta, the child is younger. And if you want to open up the space, it will open up in the region of the symphysis pubis. But in B, it is rigid. The child is older, and therefore you have to do the osteotomy to open up. In C is the BNS pericapsular. What we do, we osteotomize around the acetabulum, and then we change the position. We keep the posterior component intact, because if it's lost, it will be very difficult to readjust the acetabulum. As indicated previously, combined pelvic and femoral osteotomy must be done carefully to avoid posterior instability of the hip. Beyond a certain age, surgical treatment is unlikely to produce a stable, mobile, pain-free joint for the long term. Despite obvious gait abnormalities, bilateral pain-free dislocations probably should not be reduced after the age of 6 to 7 years. Unilateral dislocations are generally more problematic because of limb length inequality and pelvic obliquity. Therefore, reduction of unilateral dislocations is considered until adolescence. What about the complications? Redislocation after closed reduction can usually be treated by repeat closed reduction or open reduction with no deleterious effect on long-term outcome. Redislocation following open reduction is usually attributable to some flaw in the initial procedure. You have to know what to do. You have to know the proper indication to do whatever that you. Inadequate inferior capsular release. Inadequate capsulorrhaphy and posterior instability from combined pelvic and femoral osteotomies are common errors. You see, these children have a certain amount of femoral anteversion. You should correct it as you're doing a shortening procedure or doing a femoral osteotomy. You should bring it down to around 10 to 15 degrees, not more. The acetabulum, you should, if you're doing a combined osteotomy, you should do enough to maintain stability, but not too much, because this will uncover the hip posteriorly, and you'll end up having a posterior dislocation. So you should try to avoid errors. Repeat surgery is almost always necessary to correct the problem, and results are generally worse than with the primary open reduction, as I mentioned yesterday. Ischemic necrosis of the femoral head is seen with all forms of treatment. The causes include extrinsic compression of the vasculature supplying the capital femoral epiphysis. Excessive direct pressure on the cartilaginous head. Keep this in mind. It's common sense. Excessive or forceful abduction, previously failed closed treatment, and repeat surgery are associated with increased rates of ischemic necrosis. The question of whether ossification of the femoral head before treatment might affect ischemic necrosis rates is not fully resolved. The diagnosis of ischemic necrosis is based on radiographic findings that include failure of appearance of the growth of the ossific nucleus at 1 year after reduction, broadening of the femoral neck 1 year after the reduction, increased density, fragmentation of the ossified femoral head, residual deformity of the femoral head and neck after ossification. Classifications of ischemic necrosis separate partial involvement from complete necrosis, which causes progressive femoral head and neck deformity. The treatment depends on the degree of severity. In a growing child, the mechanically stable hip that is reduced but dysplastic may be monitored with serial radiographs. Failure of improvement with growth is an indication for intervention, as is symptomatic dysplasia in the adolescents. Analysis of the late dysplastic hip is facilitated by CT or MRI studies with three-dimensional reconstruction. Femoral and pelvic or concomitant osteotomy may be required according to the location of the major deformity. Pelvic osteotomies are grouped into reconstructive and salvage types. If it is possible to concentrically and congruently reduce a dysplastic hip, a reconstructive osteotomy may be indicated to improve coverage of the femoral head with the native articular cartilage of the acetabulum. Several osteotomies that reorient the acetabulum without changing its shape have been described, and the choice in large measure depends on the patient age. This is what I mentioned previously. The single innominate osteotomy or SALT depends on flexibility of the symphysis pubis. هذه قلت لكم إياها هلا. To allow sufficient rotation of the acetabular segment. In older children with flexibility lost, a triple osteotomy of stealotonis is referred to that acetabular segment of the pelvis and can be rotated without violating the triradiate cartilage potential. So what do? We osteotomize superior and inferior pubic remnants. After closure of the triradiate cartilage, the periacetabular osteotomy, BNS, is appropriate. If the intrinsic shape, يعني acetabulum is flat, if the intrinsic shape of the acetabulum must be altered to improve congruence, reshaping osteotomies, such as the Pemberton or the Dega, should be considered. As I mentioned before, I prefer the Dega. I don't like the Pemberton because it goes through the triradiate cartilage and it can interfere with the growth of the acetabulum. These osteotomies require an open triradiate cartilage to allow hinging through the acetabulum itself. The inner and outer tables of the ilium are divided in the pembroton. The inner and outer tables of the ilium are divided in the pembroton, whereas only the outer table is cut in the dega. Reshaping osteotomies of dega is shown over here. This we do in flat acetabulums. And what we do is go parallel to the upper wall of the acetabulum. We divide only one cortex, the other we leave it intact, because to reach it, we'll pass through the triradiate cartilage, and then we bend everything and put out. It decreases the size of the acetabulum. So, which preserves this? It preserves the sciatic notch and variable portion of the inner table of the ilium. Please pay attention. طلع وين السciatic notch only. This is it. This is the triradiate cartilage. We only reach this position, bend it forward, put our bone. The pembroton, it goes all the way down to the triradiate cartilage, and then it bends through the triradiate cartilage. Both proceed into the posterior limb of the triradiate and preserve the posterior wall of the ischium at the sciatic notch. Salvage osteotomies increase the surface area available for weight bearing and depend on fibrocartilage metaplasia, like the Chiari muscle, of the interposed hip capsule to form an articulating surface. The Chiari osteotomy, innominate osteotomy, and various shelf acetabular augmentations are available. I want to show you several. There's several procedures. Stanley did the shelf operation. There's one operation in which we create shivers of osteotomies over the acetabulum in a dysplastic hip and pack bone over here. This is a shelf operation. This is the Chiari. The Chiari osteotomy is done over here, and we push everything medially. You have to pay attention to this line, because if you put it in this direction, it will displace. It will go medially. But if you put it in this direction, the osteotomy, if you apply pressure from now to tomorrow, it won't go. You have to pay attention according to the line of the osteotomy over here. Now, let me show you a few cases. This is a patient who came to me having a dislocation. This child was, I think, 3 years of age. This was the various x-rays. I'm sorry about the quality of x-rays. I looked at the acetabulum. I found that it was of sufficient size. So I did an open reduction. I incised the capsule. I followed the ligamentum teres to the joint and then excised it. I made vertical incisions in the labrum. I removed the pulvinar fat pad, and I even incised vertically the transverse ligament. Then I found it easy to reduce it. But I found that this was stable in certain positions of the hip. That if I externally rotate it, it will dislocate. If I internally rotate it, it will remain in position. So what did I decide? I decided the acetabulum is good, so I just did a varus derotation osteotomy, and the hip was stable with a good capsularity. I had a good result. This is an other elderly patient. This patient, again, I'm showing you all cases more than 2 years of age. This patient had the dislocation. He was a tiptoe walker, walking on his toes. And I operated him. I did 2 forms of osteotomy because he had severe, around 80 degrees of anteversion. I did the shortening derotation osteotomy. I did the Salter osteotomy. I did the capsulorrhaphy following excision of all the soft tissues. I made it a point not to overdo it so as not to have a posterior dislocation. And this was the final result. This patient, let me see, this was the same patient later on when I removed the things. You see the acetabulum is so well formed. You see it's derotated. You can see it in neutral position, okay? So this is another patient that I did exactly the same procedure. They're all older children. This is another patient that I did. I was not very happy from this patient because he continued to have a flat acetabulum. This is another patient that came to me. He had a high riding hip. I did the procedure, and this was the result. This was a patient that I was very glad of the result. You see that the hip is very well reduced. Now we come to another topic. I want to tell you something. When operating, this operation is an easy procedure, but it requires a learning curve. You should use either the Smith-Peterson or any anterior approach. You expose the hip proximally. What I usually do is to be able to work on the acetabulum, I do my subtrochanteric osteotomy around 2 centimeters distal to the subtrochanteric zone, and I leave it free. So I work on the acetabulum, I remove all the obstacles, and I do my capsulorrhaphy when it's osteotomized. Now, the point is how much should I remove and how much correct from the anteversion which is present. And what I do with the hip reduced, stable, no one to hold it. I apply traction on the leg. I ask the anesthesiologist to give the moderate amount of anesthesia. I see the overlap of the shortened place. Then I remove this fragment of bone. I correct the anteversion. I even remove the shortened bone. I apply my plate distally. And this is what I do. Now, I put my plate. I use whatever shortening I do, I use as a bone graft. And what I should warn you, at the end of the procedure, the hip should be very stable. Yeah, and what I'm telling you is very important. Should be very stable without the cast, without anyone holding it. Yesterday, somebody asked the question, when would you do the other side? The point is that we like to immobilize the hip for 6 weeks. Then we put the child to rest. We let the physiotherapist work a bit on him for 1 to 2 weeks. And then we do the other side. And we put the child in a 1.5 spica for another 6 weeks. Then we take out the cast completely. This is if they have bilateral high riding hips. Ya Jami'a, if you do this procedure well, the hip will be so well reduced that it will not dislocate, even until you apply the hip spike. Let me tell you something else. When I apply the hip spike, I put the hip in neutral position and the leg of the same side in a neutral position. I don't put the hip in flexion. I don't put it in abduction. Please keep this in mind. Learn the way to do the proper procedure if you want to operate. I'll tell you, I want to speak more about the Chiari. The Chiari is nothing but the Salter, but the line of osteotomy should be in such a way that you can displace the distal component medially. And it should be directly in line with the upper margin of the acetabulum, so that the capsule will be interposed between it and the iliac bone. This will undergo metaplasia or change into bone and become a capsule. This has given me good result, but you're changing in the anatomy of the extremity. So keep this. This was one of the reconstructive procedures that we used to use very commonly in the past. So enough for DDH. Are there any questions? Any questions? What treatment will be offered in these two cases? ليك هلا عم بقرا الكويشنز اللي حاطينه.
في كويشن في الشات.
يلا خلينا نشوف. The first question لعلتك كل محاضرة دكتور جون نعم في شيء بالعربي أنا I don't read that. كلمة هذا مشكورين. I don't know. Everything is crystal clear. We can control the reduction with ultrasound. Ultrasound, you can, in the early phase, judge whether the hip is reduced or not. And in a way, you call it a controlled reduction. You can do it repeatedly. بس خلينا ننبهكم عن الالتراساوند. In the ultrasound, it is the experience of the radiologist. They have to have a good experience in it to depend on the results. Okay? So this is, in which situation or age you go directly to open reduction without trial of closed reduction? This you judge. You judge by seeing the x-rays and studying. You should also be able to tell how much antiversion is present. If it is a high riding hip and rigid, then I will go to open the reduction. But usually my age limit of closed reduction is 1.5 years. After that, I start resorting to open the reduction. I don't apply traction on my case. If you have a newborn with an irreducible dislocated hip, treat with Pavlik harness. It's irreducible and it's 1 month, would you say? 1 month, I would always give it a chance with the Pavlik. But the problem is you have to know when to stop. If you find that after 2 weeks, it doesn't reduce, you have to resort to other situations. Now, if after 2 weeks, the ultrasound do not show reduction, you have to resort to others. Posterior dislocation, you should never try to get this because this becomes more resistant to treatment. For a 9-month-old child who was treated with traction in bed, if the x-rays show no reduction, can we offer surgical treatment at this age? Look, you can But what I usually do, did they do an adductor tenotomy? That's one. Number two, you have to give the patient a good anesthesia, and you decide. At 9 months, you can do, of course, an open reduction. There are people who like the Ludlow approach. They will do an open reduction using a Ludlow. But what I would do, I usually use the Smith-Peterson, and I would do just an open reduction. No bony procedure. If you have a bilateral congenital dislocation, can we offer surgical treatment? Yes. I have operated on many at the age of 5 years. But you have to warn the family. You can get an excellent result. I showed you many. You can get an excellent result and good reduction. But you have to warn the family that the child in the late teens, they may have pain in the hips. So the family has to help you in the choice of treatment. But I would do it. I've done them on all cases that came at the age of 5. I've done it even in later cases. But this is not according to the rules. For iliopsoas cut, it should be at the iliomuscular junction of the tendon, muscular tendinous junction, at the brim, not distal. This will be bad. Good question. In open DDH surgery, first we try to open reduction, decided if the need of femur shortening. We can't did the reduction, we can do it shortening. I do shortening after the age of 2. But I don't do the shortening unless I've done a good capsular and I've reduced my hip. خليني قلتلو تذكروا كلامي when you're operating on these cases and you have a high riding hip and you do a subtrochanteric osteotomy, you don't realize how easy the surgery becomes. You can easily do a capsulorrhaphy, remove the iliopsoas that was causing kinking of the capsule, and open the capsule, identify the ligamentum teres, follow it distally, because at this age you might have a problem identifying the true acetabulum. In my experience, in most of my cases that had an intact ligamentum teres, in this way I followed them to the true acetabulum. The ligamentum teres, in many cases, it's hypertrophy. You should divide it. Then incise your labrum if it's inverted. Nothing else. Don't make it go out or in. Keep it in place, but incise it by these longitudinal incisions. Another point, before entering the acetabulum, you find that the transverse ligament on the inferior aspect of the acetabulum could be in the way. So you just make a vertical incision in the transverse ligament and you come to the pulvinar fat pad. You remove the pulvinar fat pad and then everything is easy. Now you've done your osteotomy. So there's nothing to control you in putting the head within the acetabulum. By just putting the head, you can judge how much derotation you need. And if there is a significant overlap between the femoral shaft and the proximal femur, then you judge how much you can remove by a moderate amount of traction. Don't remove too much. There should be some tension left in. So keep this in mind, please. I usually apply a 4-hole plate and I put 2 holes put in each, and that's enough. And with the corrected derotation, and I put the patient in the hip spica, straight, not abducted, not internally rotated, neutral position. By the time of 6 weeks, it's so damn stable. Can remove the cast, encourage the patient to move, get a good physiotherapist, work on the patient 1 to 2 weeks, and then do the other side. When you do the other side, during the procedure, you do the same procedure, but you should include, make the hip spica of 1.5 hip spica. Now, I'll tell you something. On doing the first side, and you have the hip which is sublux, I usually put the opposite hip in slight abduction. It would make things easier for the second procedure on the other side. Are there any questions? Finish?
No questions.
Is everybody satisfied?
Yes.
Khalid, are you satisfied? ما عم بسمع. ما عم نسمع.
Doctor, we are satisfied.
You are satisfied?
No more questions. We can continue.
I can continue. يا جماعة, go and read about DDH today. Okay? Read about DDH. I'm going to give you slipped capital epiphysis and then stop. I will give you leg calvipersis the next time. And this is a very meticulous subject, and I want you to learn the basics. And I will add something to it. Yalla. Slipped capital epiphysis. Slipped capital epiphysis is also called slipped upper femoral epiphysis. It is the most common hip pathology in pre-adolescents and adolescents. This diagnosis is often delayed or missed due to either atypical presentation, such as thigh or knee pain, or the chronic nature of the presentation. Believe me, many times I had patients coming to my clinic with their parents stating that they have knee pain. Whenever you get an adolescent with knee pain, don't forget, you should examine the hip. The differential diagnosis for pre-adolescent and adolescents presenting with leg pain is broad. Thus, the medical provider must always consider the diagnosis of slipped capital femoral epiphysis. Delay in the diagnosis of slipped capital femoral epiphysis is associated with higher rates of complications, including femoral head osteonecrosis. يا شباب يا ولادي, make the diagnosis early. You should be an alert physician. You should be well acquainted with the diagnosis. And the only way you can do so is by reading. Read books. Let Khalid buy you books and read them. The more you know, the better it is. Recapitulate. You know, the physis has the germinal phase, which is the resting zone. Then you have the proliferating. Then you have the zone of hypertrophy, where there's a large amount of glycogen. Then you have the zone of provisional calcification, where you have infiltration of vessels and calcification. and formation of woven bone and destruction of the zone of hypertrophy. This is the physis. This is the basis of pediatric orthopedics because we have many conditions related to it. Yesterday, when we were discussing tumors, we discussed it in relation to the physis. Was it penetrating? Was it not penetrating? How far is it from the physis? Can we do an intercalary resection or not? What happens if you excise the physis? How much leg length discrepancy would you have? Why do we have the expandable prosthesis? Because of the leg length discrepancy. So you have to know the physis. You have to know everything about the physis. So in flipped capital epiphysis, it is the zone of hypertrophy, nearly at the junction with the zone of provisional calcification that the epiphysis separates. You have a type 1 trans-epiphyseal separation. They are generally are caused by high energy trauma, whereas flipped capital epiphysis can occur insidiously, very slowly. هيدي بسميها غدارة, and minor trauma and can cause acute separation on a chronic slip. This slippage occurs at the level of the hypertrophic zone of the physis. It occurs in a distinct older age group, meaning age 10 to 16 years. 78% of patients with slipped capital femoral epiphysis are adolescents in the rapid growth phase. Don't forget this. It's during the rapid growth phase. Why? Because the zone of hypertrophy becomes larger, it's rapidly growing, and تنغدر by any bad movement that would let it slip. It is more common in obese children. Yes, it's true. Why? Because the load is much more and is almost twice as common in boys as in girls. Why? Boys are active, moving around. Girls are slow, calm. The average age of onset is 11.2 years in females and 12.0 years in males. The single most significant risk factor is obesity, the male sex, periods of rapid growth. Prior radiation therapy to the hip weakens the physis and could promote it. Retroversion of the acetabulum or femoral head, both of which increase mechanical shear forces through impingement across the physis. Several etiologic factors have been suggested for slipped capital femoral epiphysis, including local trauma, mechanical factors, especially obesity, growth spurts and puberty, inflammatory conditions. They weaken the physis, and therefore they have it. Endocrine disorders. نعرف إنه slipped capital epiphysis is common in hypothyroid patients and hypopituitarism. Why? Because they weaken the physis. Chronic renal disease, we know it's very high, and genetic factors, predisposition, and Down syndrome. Hypothyroidism is the most common etiology of non-idiopathic slipped capital epiphysis. Slipped capital femoral epiphysis presentation in a child younger than 10 years old or weighs less than the 50th percentile is an indication for endocrine workup. يعني إذا جاكم ولد عمره 10 سنين and he is smaller than normal, you can feel that this patient weighs less than other children. You kind of wonder, could there be an endocrine problem? So you should work up the patient, work him up for hypothyroidism, work him up for hypopituitarism, make sure that there's no inflammatory condition like rheumatoid arthritis occurring in children. You have to see what the cause is. You have to investigate. Laboratory testing can include thyroid stimulating hormone, thyroxine level, free T4, blood urea nitrogen. Why? For the kidneys. Likewise, for the kidneys, to rule out this patient doesn't have chronic renal failure because it's associated with slip capital femoral. It occurs twice as often in children of African descent than in children of European descent. The left hip is affected twice as often as the right, and bilateral involvement is reported to occur in 25 to 40% of children. The opposite hip slip usually occurs within 12 to 18 months. Double, 12 to 18 months. إذا أجاك ولد عنده slip capital epiphysis and you identify a Klein line, warn the family that they should continuously follow up this child because he could have a slip in 25 to 40% in 12 to 18 months. Keep this in mind. This would save you problems. Patients with open triradiate cartilage are at higher risk. Okay? We mentioned that this is between 10 and 16. Now, if the triradiate cartilage is open, you should worry. Although shear forces generally are cited as causative factors, torsional forces also play a role in slip capital femoral epiphysis. Sankar et al. Noted that if you have an increased acetabular retroversion and you have let's say, a protrusio acetabuli or overcoverage in the unaffected hip, you should worry. Why? Because biomechanically this is abnormal. Look at the profunda acetabuli with respect to the physis. If the head is in and that hip is moving, you could have impingement of the physis on the periphery of the acetabulum and it can displace. This is common sense. Okay? So you have to keep this in mind. The vulnerability of the physis, including a decrease in the neck shaft angle, the physis being in a vertical position is more susceptible to shear forces. And we know it, that if the physis is not horizontal and it's vertical, the chances for it to displace is high. In addition, we found that تعرفوا ما بين الphysis والhead والneck في perichondral ring. If this is thin, then the support for the physis is not very good. Therefore, it can displace. A change in the cellular anatomy of the physis is also a factor. Lieu et al. Also noted that the epiphyseal tubercle may be protective at an early age until it decreases in size during adolescence. Physeal widening at this age may then allow the epiphysis to internally rotate around the tubercle. The reliable orientation of the lateral epiphyseal vessel adjacent to the tubercle might explain the low rate of osteonecrosis in chronic stable slips. Okay. On examination, a limited internal rotation of the affected extremity can be present, and passive internal rotation may elicit pain. ليش? When you begin to have a slip, the whole lower femur goes into external rotation, and therefore you'll have limitation of internal rotation. There would be also loss of hip flexion, abduction, and internal rotation. What about the Drehman sign, which is obligatory external rotation with passive flexion of the hip to 90 degrees? A Drehman sign, ya shabab, when you flex the hip, if there is a slip and the hip is in external rotation, normally, if you have a normal hip, it will flex past 90. But if you have a slipped epiphysis, ما فيك reach 90. It will have to go into external rotation to reach 90. The upper margin of the acetabulum. The patient may have a shuffling, Trendelenburg, or antalgic gait, or have a complete inability to bear weight. Thigh atrophy may or may not be present. Pain is most often reported in the hip, 52%. However, pain associated with slipped capital femoral epiphysis may also be reported in the groin in 13.9%, the thigh 35%, the knee 26%. Knee pain is usually due to pain activation of the anterior obturator nerve. These are questions we ask. Why do they have pain? Because they have irritation of this nerve. So please don't forget this. The hip, when flexed, externally rotates. This is the Drehman sign. In a frog leg position because of the abnormal contact between the displaced femoral neck and the acetabular rim. Slipped capital femoral epiphysis should be suspected in patients aged 10 to 16 years who complain of vague knee pain, which may be referred pain from the hip. So please don't forget this. Chronic slips often have moderate shortening of the affected extremity. It is fixed in external rotation, leading to external rotation and a Trendelenburg gait. The diagnosis is frequently delayed, which may result in a more severe deformity and worse long-term outcomes. Delays in diagnosis occur primarily in patients with knee or distal thigh pain, Medicaid coverage with stable slips. The diagnosis of slipped capital epiphysis usually is apparent from the anterior posterior and frog leg pelvic radiographs, but special views may be helpful. The Klein line Don't forget this because we love this slide. We always ask it. Is a line along the superior aspect of the femoral neck that normally is intersected by the epiphysis. In early slips, the epiphysis is flush with or below this line, as is shown in B. Pay attention to this. Yeah, جماعة, pay attention. This shows you the Klein line. The Klein line is that the line along the superior margin of the neck does not intersect with the epiphysis or the head. Normally is what is shown in A. Abnormally is in B. The stress one sign is another name for the Klein line. عم بتخانقوا هيدا بده اياه باسمه الثاني بده اياه باسمه. In a normal hip, a line tangential to the superior femoral neck, Klein line intersects a small portion of the lateral capital epiphysis. In the posterior displacement of the epiphysis, the line does not intersect. I want to mention at this time, كلكم بتحسبوا B. The slipped capital femoral epiphysis, it is the head which is slipping. This is not true. The head is stable, present within the acetabulum. What is slipping is the femoral shaft and neck. Undergoing placement and with gradual external rotation, it slips. So keep this in mind. As a حدا سألكم, what do you think? Is it the head that's slipping? You tell them no. A modification of this measurement considered a slip to have occurred if the maximum width of the epiphysis lateral to Klein line differed 2 millimeters or more from the contralateral. Pay attention, this is shown in the slide below. This modification was reported to improve sensitivity from 40 to 80%. A double density sign is seen when you have the slip. The neck is slipping anteriorly. شو بيصير؟ بصير عندكم overlapping a bone on bone. So a double density is seen at the metaphysis on the anteroposterior radiograph as compared with the contralateral hip when the metaphysis is translated anteriorly and externally rotated relative to the epiphysis. This has been called the metaphyseal blanch sign. طلعوا بالصورة تحت. في عندك slip. الهيد موجود بمحله. But the neck is slipping anteriorly and proximally. So في عندك overlap ما بين البون تبع الابيفيسيس والneck. It appears more dense. And this is called the metaphyseal blanch sign. This shows you the blanch sign, which is more apparent. It's a double density line area. It's more apparent on the left hip. You see, it's more concentrated. On the right-hand side, you don't see it concentrated. Over here, you see في overlap. في عندك هيدي اسمها metaphyseal blanch line. MRI is often used for the diagnosis of a subtle or pre-slip condition and suggested by edema around the physis on T2 weighted images, which should be a sign that a slip is present. CT is helpful in determining if the physis is closed for preoperative planning before complex osteotomies. Previously, it has been classified according to the duration of symptoms and stability of the slip. In acute slip capital femoral epiphysis presents within 3 weeks of the onset of symptoms. A chronic slipped capital epiphysis has a more gradual onset of symptoms, more than 3 weeks duration. And then acute on chronic is one having a chronic with an acute further slipping. And this is called the temporal classification. This is a radiograph of a chronic slipped capital femoral epiphysis, which shows the epiphyseal displacement with evidence of bone healing or remodeling. You see, أول شيء بيعملوا عظم على الانفيريور aspect with evidence of bone healing or remodeling with possible secondary changes to the acetabulum and femoral neck, depending on the duration of symptoms and degrees of slip. The temporal classification of slip capital femoral epiphysis is descriptive, but has little prognostic value. The most widely accepted classification is the Loader et al. And is based on the stability of the physis. A slip is classified as unstable if severe pain prevents walking, even with crutches, regardless of the duration of symptoms. With a stable slip, walking is possible with or without crutches. Satisfactory results were obtained in 96% of stable hips, compared with 47% of unstable hips. Yani, in the unstable hip is not so stable, it will displace. While stable hips, it's stable, it's solid when you're walking. If you can use crutches and you can walk on it. The osteonecrosis rate for stable slips was 0%, compared with 47% in the unstable group with operative intervention. So you have to pay attention to this. Slipped capital femoral epiphysis can be graded based on severity of the slip. A pre-slip condition is present if there is symptomatic weakening of the physis without loss of the normal epiphyseal metaphysician. Radiographs may demonstrate irregularity, widening, and indistinctness of the physis, and MRI demonstrates abnormal edema surrounding the physis. Mild slipping, grade 1, exists when the neck is displaced less than 1/3 of the diameter of the femoral head, or when the head shaft angle deviates from normal by 30 degrees or less on either projection, described by Southwick. The Southwick slip angle measures the degree of epiphyseal displacement in relation to the diaphysis. This method is considered more sensitive in detecting slip captal femoral epiphysis. You have to know about the S sign, which consists of a line drawn along the inferior cortical outline of the femur in the frog leg lateral view that extends from the proximal femoral head neck junction to the proximal femoral physis. Normally, the cortical outlines are symmetrical without sharp turns or broken continuity. I'm sure you didn't know anything. Let me tell you it. This is how we measure the Southwick angle. We draw a line to line along the physis. Then we draw a perpendicular. And we draw a line along the longitudinal axis of the femur. And we measure the angle. Likewise, on lateral views, we do the same. So anything from less than 30 degrees is a stage 1, more than 30 to 60 stage 2, and then you have 60 and above is stage 3. This is the Southwick. Now let me tell you, and let me speak about, first of all, I don't want to interfere with some of my lecture. In moderate slipping, grade 2, the neck is displaced between 1/3 and 1/2 of the diameter of the femoral head, اللي حكيتكم عنها, or the head shaft angle deviates between 30 and 60 degrees from the normal on either view. Grade 3 is characterized by neck displacement of more than half the diameter of the head or deviation of the head shaft angle by 60 degrees. هيدا قلت لكم إياها. هلا خليني اقول لكم what is the S sign. إذا عم تعملوا frog leg views, إذا بتعملوا زيح على النك, it will be continuous with that of the epiphysis. إذا عندك slip, it becomes broken. And this is the S sign. Please don't forget this. Slip capital epiphysis also can be idiopathic, atypical, associated with renal failure, radiation therapy, hypogonadism, Down syndrome, and various endocrine disorders. Children younger than 10 years old or older than 16 have been reported to be 4.2 times more likely to have atypical slip capital femoral epiphysis and 8.4 times more likely if the weight was below the 50th percentile. Slips occurring in children with underlying endocrinopathies or other risk factors may be susceptible to failure of screw fixation, progressive slipping, or contralateral slipping. When symptoms of pain continue, average 5 months, in such patients, close follow-up with radiographs or prophylactic pinning is necessary. Some authors have advocated treatment with pins that are smooth proximally and threaded distally to engage the anterolateral femoral cortex with no threads crossing the physis to allow continued growth in younger patients with renal osteodystrophy. خلينا لكم اياها هيك. هلا بفسركم اياها على الدايجرام. A single cannulated 7 mm diameter screw with 10 mm threads also can be used. The screw should be placed in the center line of the femoral head so that all screw heads are within the femoral head and not in the joint and not in the physis. The screw is left protruding 15 to 20 millimeters to allow for further growth. شو النفع تحطوا threaded screw across the physis? شو النفع? It will block growth. You should have all types of screws available at all lengths and all lengths of threaded portions to be localized within the epiphyseal ossification center and nothing across the physis so as to allow growth. نخليها شوية 15 to 20 millimeters حتى يقدر الواحد to grow. This is showing you. Look at the threaded portion which is in the epiphyseal ossification center. Nothing through the physis, and it's left out for a certain amount so that left for growth. On the other hand, you can put the screw which is threaded outside and smooth inside, and this will allow for growth. We like to apply the screw centrally. And one of the most important points is not to allow the screw to penetrate into the articulation, because this would lead to cartilage necrosis. So the ideal treatment of slipped capital femoral epiphysis would be to restore the biomechanics of the hip, prevent additional slipping of the epiphysis, stimulate early physeal closure while avoiding the complications of osteonecrosis, cartilage necrosis or chondrolysis, and osteoarthritis. The methods of operative treatment of slipped capital femoral epiphysis have included percutaneous and open in situ pinning, open reduction, and internal fixation, epiphysiodesis, osteotomy, reconstruction by arthroplasty, arthrodesis, or calectomy. Each technique has its proponents and opponents, and the choice of treatment must be individualized for each child depending on age, type of slip, and severity of displacement. In situ pin or screw fixation. Percutaneous in situ screw fixation currently is the most commonly used treatment for both stable and unstable slipped capital femoral epiphysis, regardless of the severity of the slip. Modern cannulated screw systems allow more accurate placement of screws and have become the implant of choice for fixation. Earlier reports indicated that 2 or 3 pins were necessary for stability. Several studies have failed to demonstrate a clinical or biomechanical advantage to multiple pins and advocate the use of a single larger diameter screw inserted into the center position of the epiphysis. A second screw is indicated if a high-grade slip is present and a single screw does not achieve adequate stability of the unstable slipped capital femoral epiphysis. An open procedure may be performed to restore the epiphyseal alignment and achieve stability. For unstable slips, a gentle or incidental reduction may be applied by simple positioning the patient in the appropriate position on the operative table. Forceful manipulation of the hip should be avoided because of the high association between a manipulative reduction and osteonecrosis. Let me tell you and teach myself with you. خليني أقولكم شغلة. I recently attended one of my colleagues giving a lecture, and he stressed that the pin, when applied, should be perpendicular to the physis on both views. The only way he could get them perpendicular was going through the anterior cortex, so as to be perpendicular. This is one of the techniques used, but you should not leave it out too much because it will impinge on the tip of the acetabulum. Another warning sign, when you're putting pins inside, you should not go at all below the lesser trochanter. Why? Because we have experienced fractures in that area following pin insertion and follow-up of the patients. Pinning the appropriate starting point to allow the passage of the screw perpendicular to the physis and into the center position is important. However, Mercer noted that a screw passed obliquely across the physis into the center position does not significantly alter the biomechanical stability of the construct. But let me tell you something, and this is very important. When we insert the threaded screw, or when we insert a smooth pin, for it to allow growth of the physis, it has to be perpendicular to the physis. Otherwise, it will interfere with the growth in length. You have to reason this out in your mind. But Merce still believed that if a screw was oblique, why not? It would do the same purpose. I personally don't realize this. I would like it to be perpendicular. So the screw should be perpendicular to the physis and central in the head, both in the anteroposterior and lateral view. مش بس وحدي. In order to achieve that, the entry point should be anterior in the proximal femur. However, care should be taken not to be medial to the intertrochanteric line to avoid impingement, inflection between the acetabulum and the screw head. Okay, so this is it. Now, so avoid screw placement that results in dynamic impingement of the screw head. Persistent screw penetration has been the most serious disadvantage of in situ fixation. Adverse effects attributed to unrecognized implant penetration include joint sepsis, localized acetabular erosion, synovitis, postoperative hip pain, chondrolysis, and late degenerative arthritis. You should take this seriously as you're putting the pin. Don't let it. It should reach only 3 or 4 millimeters from the cortex. And you should be sure of it. You should take AP and lateral X-rays or use a scope to make sure that you had not penetrate into the acetabulum. As a practical clinical guide, placing the screw in the center of the femoral head no closer than 4 millimeters from the subchondral bone helps to decrease the prevalence of screw penetration. These are areas which I would like to stress. I put this up. Yani, when you go in with your screw, you have to make sure that the length of the threaded position fills in the epiphyseal bone, not the physis. It should not cross the physis. Now, the central axis of the screw is located over the center line of the femoral head or within distance equal to 1/2 diameter of the screw, ideal position. The position 2, the distance between the axis of the screw and the center line of the femoral head is between 1/2 and 1 screw diameter. Position 3, axis of the screw is more than 1 screw diameter from the center line. Position is given as 2 numbers. First for position of screw, anterior-posterior radiograph, and second for position as seen in the lateral view. So these are just how to put the screw in. Multiple radiographic views could be obtained to ensure persistent penetration has not occurred. Other methods, such as the passage of the blunt end of the guide wire or injection of contrast dye through the cannulated screw, have been described. Avoid inserting any screw distal to the lesser trochanter also. So don't penetrate the screw into the joint and avoid inserting a screw distal to the lesser trochanter. Post-operatively, patients are allowed to bear weight after fixation in case of a stable slip and partial weight bearing for 6 weeks in unstable slips. Capsulotomy has been shown to reduce intracapsular pressure in unstable slip capital femoral epiphysis. There is no clear evidence that it reduces avascular necrosis rate. Prophylactic fixation of the contralateral hip is another controversial modality. Currently, it is indicated where there are high risk factors for a contralateral slip, such as obesity, male gender, initial slip in a younger than 10 years old, endocrine disorders. Open reduction and internal fixation of the slipped epiphysis, the modified Don procedure. This is one of the modern techniques used, but there is an associated high incidence of avascular necrosis with this procedure. The aim is to correct the deformity of the proximal femur and stabilize the epiphysis, meanwhile protecting the femoral head and blood supply. The procedure involves the surgical dislocation of the hip through the Gibson approach. The patient is positioned in the lateral decubitus position. The incision is straight lateral over the greater trochanter. The approach utilizes the plane between gluteus maximus and medius. A trochanteric flip osteotomy is performed. A Z-shaped anterior capsulotomy is to expose the metaphysis. The slipped epiphysis is initially primarily stabilized by a K-wire. And this is a warning. Once I was doing it without the K-wire and I had a complete slip. Luckily, it was for my benefit. I reduced it better, and I put the pin in. But at times, don't always say it's lucky, because it can end up with osteonecrosis for sure. So the slipped epiphysis is initially primarily stabilized by K-wire prior to dislocation. Then the hip is dislocated using a hook around the femoral neck for traction. Once the hip is dislocated, an incision of the periosteum is performed over the anterior neck and proximal femur to the lesser trochanter. Periosteal flaps are elevated bluntly, anteriorly and posteriorly. The epiphysis is freed completely from the metaphysis using a chisel. Then the metaphysis is debrided. We debride the metaphysis. The epiphysis is reduced and fixed to the metaphysis using 2 or 3 K wires, both antegrade and retrograde. What I mean retrograde is to insert it through the metaphysis and then bring it up again. Antegrade going directly. Post-operatively, patients are instructed to partially weight bear for 6 weeks. Believe me, in the good results, it's really nice to have. But you can have osteonecrosis in 40% of your patients. Dr. John was very courageous in doing it. This is another controversial management modality that is indicated in unstable and severe slips. It is performed through a modified Dunn procedure, which is capital realignment. After initial management, patients may develop consequences that can be symptomatic, and these can also be addressed by operative management, such as femoral acetabular impingement as a result of the CAM lesion from a metaphyseal bump, or cases of slip capital femoral epiphysis deformity with a slip angle of less than 30 degrees. Both can be managed by osteochondroplasty. However, cases of severe slipped capital femoral epiphysis deformity with a slip of greater than 30 to 45 degrees, which is painful or limiting function in the absence of hip osteoarthritis or osteonecrosis, can be managed by proximal femoral osteotomy. Several proximal femoral osteotomies have been described in the literature, with the most commonly used one being intertrochanteric or the Imhoser osteotomy. The greatest deformity correction can be achieved by femoral neck uniform osteotomy. Again, we have the same risk, avascular necrosis. Also, the subtrochanteric Saswick osteotomy has been described. I have performed several of these. It gives good results, but it doesn't give you an anatomic final result. Osteochondroplasty is indicated in mild and moderate chronic slip capital femoral epiphysis deformity, cases where a prominent metaphyseal bump results in pain and a restricted range of motion. Osteochondroplasty can be performed arthroscopically with a burr or through a limited anterior arthrotomy via a modified Smith-Peterson approach. Also, it can be performed through surgical dislocation of the hip and using a curved osteotomy to remove the bump along with a burr to reshape the contour of the head-neck junction. The differential diagnosis in these cases, I just would like to mention, of slipped capital epiphysis should include infectious etiologies such as septic arthritis, osteomyelitis, in particular, if the patient is febrile or ill appearing. If the onset of pain is reported in the context of sports injury or other traumatic injury, etiologies such as avulsion of the anterior iliac spine, adductor muscle strain, ligamentous knee injury, and femur or pelvic fractures should be considered. So keep this. You have to learn a differential diagnosis. Inflammatory processes such as transient synovitis, leg calciferous disease, Osgood-Schlatter's disease can also be considered in the appropriate clinical context. If the patient has a clinical exam that seems consistent with slipped capital epiphysis, even if other clinical features are atypical, the clinician should strongly consider obtaining a plain radiograph of the hips. So, the take-home message. Staging. The Lauder classification was introduced in 1993 based on the ability to bear weight and helps to predict osteonecrosis. Cases can be classified as stable if the patient is able to bear weight with or without crutches. Those cases would have less than 10% risk of osteonecrosis. Unstable if the patient is unable to bear weight, and these cases carry a higher risk of osteonecrosis, 24 to 47%. Temporal Lauder classification, where they divide it into stable and unstable. Be careful. The Southwick slip angle grades the severity of slip capital femoral epiphysis based on the difference of epiphyseal-diaphyseal angle between the affected hip and the unaffected contralateral hip, both in anteroposterior and lateral radiograph of the hip. Mild cases less than 30 degrees, moderate cases 30 to 50 degrees, and more severe 50 to 60. The temporal classification is based on the duration of symptoms. It is seldom used as it has no bearing on prognosis. It is considered acute if symptoms are present for less than 3 weeks. Chronic if symptoms persist for more than 3 weeks, or acute on chronic if a patient has worsening of the symptoms that have been present for more than 3 weeks. Slipped capital femoral epiphysis can also be graded based on the percentage. So you have to be careful about this. The complications, don't forget that femoral growth arrest due to premature closure of the physis, femoral head osteonecrosis, chondrolysis, femoral acetabular impingement, labral tears, infection, chronic pain, development of slipped capital femoral epiphysis in the contralateral hip, later complications of slipped capital femoral epiphysis include early onset of osteoarthritis of the hip. Femoral head osteonecrosis could be a consequence of initial injury with a higher risk of unstable slipped capital femoral epiphysis. It can also develop as a post-operative complication as a result of metalwork placement in posterior superior aspect of the femoral neck, where it poses a risk for disrupting the femoral neck blood supply. Chondrolysis could be a consequence of articular surface penetration. Patients will usually present with pain and a reduced range of motion. Radiographs will show reduced joint space. A CT scan would be the best modality to assess metalwork penetration. Femoral acetabular impingement, which I have mentioned, is due to failure of proximal femoral remodeling, and this is known as the pistol grip deformity. This can be addressed as mentioned earlier by proximal femoral osteotomy. Slip progression, this has been reported in 1 to 2% of cases with single screw fixation. Yeah, thank you very much. I think I gave you enough today. I'll tell you, I hope you benefited. I hope you learned. And please let me know if there's any misunderstandings. شو يا خالد؟ خالد
دكتور يا عم نسمعك.
بدي اياك تحكيني. انا فكري neck calviferous disease بدها تفسير كثير. فكري اعطيها مع شيء ثاني بعد جمعتين. لان you have to explain to them the cateral classification, Waldstrom's classification, في عندك Salter Thompson, في عندك so many points you have to explain to the resident. I know when I was a resident, I had quite a bit of difficulty in this. بس شو بدكم ياني كمل؟ أنا حاضر. ما بدكم ياني كمل؟ فضل إنه خليها لمرة الجاية. شو رأيكم؟ شو بدكم؟ ما عم بسمع.
تسمعني دكتور الآن؟
Next week, next Friday after, شو بدكم؟
اوكي دكتور next week.
Okay, فاز عند Friday after.
اوكي.
شو بدكم؟ أو بنكمل، أنا ما عندي مانع، بس it will be quick. وأنا خايف ما يفهموها.
طب
شو يا خالد؟
دكتور جو؟
ايه يا ريت تحكوني على التليفون، يا ريت تحكوني على التليفون. لما ما عم بسمع.
اوكي دكتور بدور.
حكوني على التليفون. Okay, فازن I'm going to stop sharing. خالد وينك؟
دكتور انا معك، دكتور صلاح معك دكتور.
بعدك بالسعودية؟
لا اللي بيكلمك الدكتور صلاح، دكتور خالد مش موجود.
لا بدي اعرف انت استفدت من اللكشر؟
دكتور استفدنا جميعا، الشباب كلهم موجودين في القاعة.
Do you think it was a good lecture?
Very good يا دكتور، نشكرك جزيلا بصراحة.
وبدي اسال العذار هاي كيف حاسس؟ كيف عملت؟ كيف كان اللكشر تبعي؟
لا المحاضرة ممتازة جدا، والدكاترة الشباب متشكرين جدا دكتور.
طيب ليك جمعتي الجمعتين اللي بعدها بعد جمعتين.
اوكي.
رح نعملها نعمل لك بيرسيز وبقشع على البروجرام شيء ثاني بحطها معه. اوكي؟ ليش؟ بدي اخذ وقت فيها، بدي اياكم تعرفوها، بدي اياكم تكونوا ملوك بالكاترال كلاسيفيكيشن. كيف وشو الكومبليكيشن؟ I think this is very important. اوكي؟
اوكي دكتور.
يلا باي.
شكرا جزيلا دكتور، شكرا جزيلا.
هاي خالد.
دكتور خالد شلون؟ دكتور جون